Welcome to the closing keynote panel for HETT North. Thank you all for coming and for staying for the whole day. I'm sure most of you will agree that it's been a fascinating day with some great discussions, some open discussions, and perhaps some difficult questions. But now I'm joined by a provocative closing panel. I, of course, am not going to ask any provocative questions and just be my normal, mild self. And I've got a great panel that are going to speak to us about some of their thoughts on digital transformation, the landscape, and some of the challenges, past, present, and future. So I'm Sam Shah, the chair of the HETT Steering Committee, and I'm joined by four other members of HETT Steering Committee who will introduce themselves in a moment. To you, Clive.
Thanks, Sam. I'm Chief Digital Officer of Patient Safety Learning, Clive Flashman. I have a portfolio of roles. So I do that. I also work in the NHS for a day a week for South Central and West Commissioning Support Unit. I've been associated with Orca as Director of Strategy for many years, when there were about 8 of us, I think. There's about 20 times that number now. And I also do a lot of work mentoring startups, mainly in the digital healthcare space.
Henrietta.
Oh, that's me thinking I was really busy. I can beat that. So I'm Henrietta Mbia-Bankas. I'm head of blended learning and lead for digital learning and development at Health Education England. I am also a registered mental health nurse and an NHS clinical entrepreneur.
Liz, I would ask you to introduce yourself, but if there's somebody who doesn't know you, I don't know where they've been.
Okay. Yeah, put your hands with you if you've not met me. I am a speech therapist by background, and that's why I blame the fact that I like to talk to everybody, so I put it directly on my clinical training. So I'm the founding chief exec at Orca, but I'm also the vice chair on the Health and Social Care Council at Tech UK.
Tremaine.
Awesome. I'm Tremaine. I'm the head of emerging technology at Northampton General Hospital and also lead the automation accelerator and need a shorter title.
So we're going to talk about digital transformation, and I've heard the word banded around. It means lots of different things. It's sometimes used as an excuse for things that happen in the system, but really I want to know about the past, the present, the future. And let's start off. What do you think has been the greatest enabler of meaningful transformation in the NHS in the past, and how do we replicate it in the future? I want to start with you, Liz, because we've spoken about this before in lots of different fora, and I want to hear about what your thoughts are on this.
Okay, thank you. So I just shared with you that I trained as a speech and language therapist. That was nearly 25 years ago. And my big passion from being very young was I wanted to help people, and that is my passion today. I still just want to get up and I want to help people. And that's really what drove me into working as a clinician in the NHS. But of course, when I started working, there was no technology. The smartphone hadn't been even created. I'd never used a computer or sent an email, but I still believed that I could help people. However, as a clinician on my first day all those years ago, what I felt was masses of frustration. And that frustration was I could only see one patient at a time. And at the end of my first day, I'd only seen 6 patients. And I thought, how can we transform this? How can we change the way in which we deliver healthcare? And that took me on a journey. And I think over the last 25 years, I've seen huge amounts of transformation. Of course, 25 years ago, we didn't call it transformation. We called it quality improvement, where we redesigned pathways and stripped out waste. But the reason I got excited about digital and technology is because what it gives us is an opportunity to do things very differently. And of course, deploying digital health to the infrastructure that we all now have, the smartphone, means that we can support millions of people at the same time. And for me, we're at the start of that transformational journey. There's still a lot of work to do, but I think that that's been truly transformational.
Tremaine, you're in the middle of an NHS organisation. What do you think? Does it feel like transformation is happening, or is it just another spreadsheet from the centre which is thrown at you?
So I think it is happening, but to use a quote, I remember there was a clinician retiring, and she said, if I tell you the story of technology in the NHS, 15 years ago, I had this much to do, and now I have computers and all these things to do, and it takes me this much time per patient. And I think the reality is there is lots of good stuff going on in the NHS, lots of innovation. I think the challenge is sort of taking that part-baked cake and turning it into something end-to-end. So there's lots of great ingredients and technologies, but they're not always pieced in a way that impact and help meaningful change. And I think that's going to be key to enabling us to actually unlock that.
And what tools, technologies, systems do you think really got the potential to improve health? Because I've heard lots of things being spoken about, whether it happens to be apps, RPA, this strange thing called AI that people talk about. But what is it that is going to make a real difference, especially for the next 100 years? Henrietta, I might start off with you because I think you should tell people about your role in the Total Review and why this is important. And what is it that you think about tools?
So that is a really interesting question. As you were talking, my brain just kept thinking COVID, COVID, COVID. So in terms of digital transformation, we've had lots of conversations about what needs transforming over the years. And in some respect, I mean, if I look at the Total Review, we did a heat map of what specific technologies were going to impact us in the next 5, 10, 15 years. And as a result of that, what implications it's going to have for us and what we needed to do, which is, in a nutshell, get a digitally ready workforce. Now, a lot of that 5-year prediction has already happened with thanks to COVID. So sometimes I think the tools are there, they're already existing, the skills are there in different places. It's not consistent, so we need to ensure some consistency or equitable access to those tools, the skills. I think sometimes the problem is spreading those things. So it's very much, you hear the statement, oh, can't wait to go back to normal. So what we've seen is with the pandemic, people have had to transform and embrace digital and do things. But then there is this notion of the normal, which is maybe moving out of that transformation. So there is something about actually what is the new normal and using these tools.
And these tools, do you think it was clinicians that sort of just decided they're going to start using them? Was it because of the top-down push to use them? Was it because they were free? Or was it because someone somewhere in the system was getting paid for someone to use them? What was it that made these tools get adopted?
A number of things. And I mean, I was in this room earlier on, and for me, it's also important. All of these tools, adoption, spread, it's about people, it's about change, and it's about behavior, right? How do we bring the two together, change people's behavior? We need to be able to give them that capability. They need to be motivated, but they need the opportunity to actually make this happen. And I think sometimes the difficulty is culturally, there are things that we do, that means that people have to ask permission to do things. And I think we can have all the right tools and all the right, if we haven't got a culture that fosters, get it wrong really quickly, let's learn from it, then people become risk averse. I do not want to be the one that touches this thing that breaks. So personally, I'll do and ask for forgiveness. And that's the only way you see transformation.
But this sounds really difficult, right? Because everyone here can't necessarily be in that place where they get on with it, do it, and ask for forgiveness. And we've got these mediators in the system that many of you will have worked with. Clive, I want your view on this. Look, we've got a whole bunch of AHSNs and lots of other bodies doing this innovation adoption thing, putting these tools out there. Does it work? What's wrong with it?
It's fragmented. So I think that the willingness to do it is there, but I don't think that the innovation framework is there yet. And I've sat on both sides of the fence. I do work in the NHS, and I also work with startups, and I do have a startup myself. And the problem is the white noise. So in the NHS, and I know a lot of colleagues in the NHS who no longer look at their LinkedIn messages because they get so many, they cannot cope with it because they are getting innovators bashing down their virtual LinkedIn door all the time. You've got to look at us, you've got to look at us. And they can't, they really can't. But it works the other way around because these innovators have to rise above the noise to get their voices heard because there is so much interesting stuff happening out there. So the question is, how do you filter it? How do you actually get the right people doing the right solutions that generate the most impact to then meet the NHS decision makers that they can work with to demonstrate, first of all, to demonstrate their impact, and secondly, to scale up and show that they can have that impact over a whole healthcare system. Now, I'm very supportive of the AAC, Accelerated Access Collaborative, the new NHS Innovation Service, which is, I think, probably trying to do what the Atlas of Solutions was set up to do with the HSNs and never did, which is to have this catalogue of all innovation. I don't know how it's going to be categorized, but it's a good idea if it works. The Atlas of Solutions never worked. But there is something around this filtering. How do you make sure that, you know, if an AHSN gets 16 diabetes solutions in 12 months, how do they decide which one to take to their local trusts? How do they know which ones to trial or which ones to scale? At the moment, it's very subjective. Very few of them have health economics units. They don't do quantitative analysis. And so therefore, it's very subjective. And I think we need a better way of doing it. And one of the things that we've ignored up until now is the third step of population health management, which is impactability modelling. So you've got risk stratification, you've got cohort identification. The next stage is impactability. What I think we need to do is to put in some sort of light framework for the AHSNs to use so that they can work out what the impact of a solution would be very quickly for their target population in their area. It's exactly what Big Pharma does with their drugs. If they've got 10 drugs that are going to help me get my hair back, please God, if they've got 10 drugs that are going to help you get your hair back, how do they choose which one they're going to take to clinical trial? They do impactability modelling. If pharma can do it, we should be able to do it in healthcare.
I mean, how often, when you've got people knocking down the door, trying to sell you something, or they've got a great solution, do you have to go through that assessment process, and what do you look for?
Oh, I mean, we've got the opposite problem where we exist because a load of the NHS got too good at being sold to during COVID, bought a load of stuff, but no one sat back and thought, what problem are we trying to solve? So we've kind of, RPA is an example, people bought a load of licensing and then went, this sounded good, but what do I do with it? And that's a lot of the problem here is that, you know, for me, I don't mind being sold to and having those conversations because I know what problems I'm trying to solve. So I can have that open conversation of, yeah, actually, this is solving this thing I'm working on right now, great, or I'll park it till later. But you often find, I often use the clinical sort of, not terminology, but you know when you go to a pharmacist and you've got a prescription, a lot of clinicians will come with, I've prescribed myself this technology solution, I've talked to no one about the problem, I've not looked at it, but I know this is the best thing for me. So it's kind of trying to play back some of that methodology and sort of support with finding the right solution at the right time. And also the other problem is everyone is going off and buying different things in different places. So you've got this sort of landscape where every single innovation is in existence in the NHS. It's just not at scale.
Isn't that all right? Isn't that okay? Like, didn't someone once say, let 1,000 flowers bloom? I'm sure somebody must have said that.
So I think it's good if you invest in the ability to actually deploy it. So I think the challenge has been there's been funding to go off and get it, but there hasn't necessarily been that continuity to say, okay, and then you're going to get funding to do the rollout, to do the change management, to do the support that's needed. And like, no other organisation has been successful with trying to get 300 organisations to all do it and get to different speeds. So I think, collaboration, any collaboration that's happening is good. People working together, working at scale and ICBs and all that sort of stuff.
Can I pick up the 1,000 flower bloom thing?
Oh, let's hear about it.
From a patient's perspective, it's a flipping nightmare because you've got so many solutions out there and they don't follow the patient, they follow the condition. So actually, as a patient, I could be recommended a dozen different solutions, whether they're traditional or digital, to help me because I might have a metabolic syndrome. So I might have diabetes, I might have hypertension, I might have a kidney problem, I'm overweight, all of this other sorts of stuff. And actually, to deal with that, I get directed to a whole bunch of different solutions. And actually, it's really difficult for me as a patient to look at those and think, how do I deal with them? Secondly, they don't share the data, so nobody has a full view of my condition. And secondly, in just the same way that drugs have adverse interactions, so do digital solutions. I could have a diabetes app telling me to eat this food that has high salt. I could have a hypertension app telling me to eat this food that has high carbs or high sugar. And they don't talk to each other. And what do I as a patient do when I've got that conflicting advice? So it's a very difficult situation for patients. And I would really like to see, and we'll come to this later, solutions that follow the patient, not the condition.
But what are the underlying problems in the health system that we need to solve if we're going to get around this? Because this isn't a new problem. This has been going on for ages, whether it's the development of clinical services or tech now. And this is probably a barrier to adoption. But what is it about the system? Is there something fundamentally different that we need to do in the next 100 years that goes... Liz, please.
Yeah, I mean, I always use the analogy of how we distribute drugs. And Clive and Tremaine were talking about this as an analogy. But if I just took you through that analogy and then we think about this in relation to digital health and where we need to get to. So in the world of pharmaceuticals, before a new innovative drug gets to market, it goes through evaluation processes. We know what the impact's going to be. We know whether it's going to be effective and when it's going to be effective and who it's going to be effective for. We then have a workforce that are trained in knowing about these drugs. It sounds really simple, but not all of us can prescribe drugs. The next thing is we then have a coordinated environment, a formulary, the British National Formulary, that tells us about those drugs, tells us about those contraindications. And then we have a prescription process which allows for governance and reimbursement. And what we've done with digital health technologies predominantly traditionally is we've bought single point solutions for a specific requirement at a single point need. You wouldn't do that in the world of drugs. Would you buy one diabetic drug? No, you have an ecosystem of drugs. Because what we know is that different people will need different drugs.
Doesn't it depend on how dominant a big pharma player might be if you only have one drug or many? A bit like a big dominant EPR player.
Exactly. And so what we need to do is understand the problem that we have and then look to the market and bring in a range so that we have choice. One of the beautiful things about the NHS is we always have provided choice. This isn't about a single point solution. And what we've been doing at Orca is a whole load of research and health economic modelling, which shows that if you think about a whole pathway, so if you take the diabetes pathway and we take the whole pathway and think about what technologies can support across that pathway, you might be buying 30 or 40 technologies, but the ROI is so much greater. The impact will be so much better because people will be getting the right technology at the right point. Then we can come on to the data piece. So I happen to actually live with type 1 diabetes. I get what you're saying. I don't want lots of different technologies. What I want is a platform of data which my choice of technology can feed so that I can see trends. That's where we've got to get to. But until we make the right choice about which technology, in the same way we do with drugs, we're not going to get there.
Henrietta, go on.
Yeah, so running with the drugs analogy, I think it's fantastic. And what you've talked through, Liz, is brilliant. But I think it then gets to the point where the person has to actually take those options they've got. So you then end up with saying, actually, we've done all the randomized control trial. This is the best concoction, or this is the best options for you. But the individual that needs to take it, we do know that a lot of money is being thrown down the drain where people have been prescribed drugs and they're not taking it. So I think that's where, for me, the whole digital health literacy piece comes in. Because whilst we are doing all of that, we need people to have that knowledge and the skills to be able to utilize the process at the end point, which is around that implementation. Because I've now got this drug, which is fantastic, but what do I do with it? Because I haven't got that knowledge and the skill, I won't be able to use it effectively as is, and I won't be able to spread the use of it. So certainly there's an ongoing piece of work looking at innovation, spread and adoption, and how we start to get that right through. So it shouldn't be something that sits with an AHSN or sits with somebody else. Actually, how can we start to think about this through all our clinical careers and through a number
and the
of
only
areas.
thing I'd just add to that is I completely agree. However, we don't stop prescribing drugs because patients might not take them. What we're doing, though, is not recommending and embedding digital health technologies because of that. So what we've got to do is start the journey and deal with the problems as they come up in the same way we do in other interventions.
I'd be interested in Tremaine's take on this, and particularly because this very thing happened earlier on where there was a discussion about rolling out electronic prescribing, but the only reason we might not do it is because apparently there isn't funding in the system, although there'll be a saving later on because there'll be different ways of getting medicines to patients and the benefits of this. So do we have a fundamental issue in the way in which digital transformation is supported and enabled?
Yes. So I think to use your analogy, it's a bit like there being 10 medicines, and if you buy one, you get it at 100% of the cost, and if you buy more than two, you get it at, say, 10%. And we all go off, and we all buy them separately and spend inordinate amounts more than we needed to when we could have come together. So that's one problem. I think also there's a sort of pharmacist problem of, I think, as you said, no one really, I haven't seen many people do innovation in the NHS in a way that they were sort of asked to do it. It was, I had this burning problem, I didn't wait for anything, I just fixed it, and everyone goes, oh, isn't that great, do more of that. But we're not going to help you get there, but we're going to, when you do get there, we'll champion it and drive it forward. So it's almost like we need to, what I see a lot of is there isn't, so in other organisations and other sectors, you'd have like a process improvement team that would sit in a organisation, would help streamline the process and build out solutions that steps back and looks at the ecosystem, where what we have is people get very good at creating solutions, and we see a lot of what I call a Ferrari to horse problem in a process, where a patient gets like thrown through the first bit of a process because someone innovated it, then back to paper, and then back to something really cool. And you end up with this like, no one looked at the bigger picture, which is the whole point of getting like, 500 different appointments on the same time, in the same hospital, with different specialties. And it's that piece of, we need to invest in the digital pharmacist.
You've just been watching the referral from my practice to Guy's Hospital. That is the process, by the way. I'm sure you were spying. So thinking about, is Guy's Hospital, by the way, in London that has this awful process. So thinking about like the policy environment, at the moment, does anyone here think that the policy that surrounds digital transformation for integrated care, which I keep hearing about, patient-centric care, do we think it's fit for purpose? Clive, what are your thoughts? You've been doing this for a while.
You're commenting on my age, Sam.
Yeah.
No, I don't think it's fit for purpose, otherwise it would be working. And I'll pick one thing, okay? Because there's so many things you could pick. But I'll pick one thing, which is money. Money is quite a big thing. And years ago, they did a trial up, I think in Leeds, something called the Year of Care Tariff. And what they looked at was if you were going to look at the reimbursement around a patient for all of the different types of care they had for a year, what would that look like, and how would you make sure that that reimbursement was spread out equitably across all of the different care organisations? When we were through COVID, we had block contracts. We're now going back to payment by results, which everybody agrees is a perverse incentive to get more people into hospital, not that they need it because they can't cope as it is. So the issue is sorting out the reimbursement around population health management. We haven't cracked that, and we can have integrated care systems and integrated care boards. They can try and commission things in an integrated way. But if they don't sort out the money and how organisations are going to be reimbursed and paid to help prevent people get treatment, then the whole thing is not going to work. And as far as I've seen, nobody yet has cracked that properly.
So we had the Topol review, and Henrietta, there were lots of recommendations in that, including things that came out of the review around reimbursement and systems and all the other things. But putting the reimbursement aside, is the rest of the policy environment that's followed, is that right? Can we make digital transformation now happen, or is there something fundamentally missing?
I think there is a lot of work to be done, starting from, I get really frustrated when I go into rooms where we're still talking health and social care. We're still talking about them separately. So fundamentally, until we start talking about them together, you hear statements like, oh, social care is too disparate and it's too... the fact that it's difficult doesn't mean we shouldn't have the conversation. So I think until we are prepared to actually start having those difficult conversations, then 10, 20, 30 years down the line, we will have ICSs, but it will not realize that transformation that we needed to realize.
If I was playing devil's advocate, wouldn't I say that, well, ICSs aren't funded for social care, they're funded for health?
It doesn't matter, because if we are talking about the person, so again, this is one frustration of mine, and anybody that knows me, I mean, to the point where my social care colleagues have given me an honorary social care worker status, because, listen, I'm always the one that's saying, why are we having this conversation separately? We are talking about integration, and why can't we talk about the two? Because really and truly, until we start to think about the whole person, we are not going anywhere. We will continue to have this conversation, and we will continue to say social care is, the poorer relative of the lot. So it's very much, I mean, and sometimes, yes, the investment may well be for health, but if we don't even address the tiny little social care need of that individual, actually, it's going to cost us a lot more for health.
Well, we'll continue having block beds, won't we? I know I shouldn't say that because you're not meant to, but ultimately, social care is the reason why a third of all the beds in the NHS are full of people medically fit to be discharged. If we don't tackle social care, we're never going to get rid of that problem in the NHS.
So that feels like one very big problem that we need to work out and solve. So we've had 75 years of the NHS so far, and hopefully there's another 75 years at least ahead of us. But thinking about digital transformation in particular, what are the key areas in which we have opportunities for digital transformation going forwards as we head into the next 75 years? I'll be grateful for all of your closing remarks and views on this, but Tremaine, I'll start with you.
No pressure. So I think for me, one is the scale in which we're doing things. So actually, for the challenges that system working has, from a digital perspective, it has huge potential. So the more we do at scale, the easier it's going to become. Also, I think making an ecosystem of technologies that glue together, that actually are to tackle specific problems, is another thing. And the fourth, which I'd say is training, because one other thing we haven't spoken about, which is like integral to this, is it's going to cost a load of money to just constantly get consultants and external people to support us with these technologies. We need to grow it from within and be planning sort of 10 plus years. And the final part is getting that policy piece right of actually blueprinting correctly. So what does good look like, because we're all inventing it. So that all of those together, I think, give us a good NHS, hopefully in slightly less than 75 years.
Liz?
I'm going to pick two. I could probably have picked 200, but I'm going to pick two. One is the workforce. So we are still not training our future clinical medical teams to be aware of what we need to do from a digital perspective. I lecture quite often pre-graduate trained medics, and when I start saying the word digital health, I am met with blank stares, and these are young people who have no idea of how to use digital health, and they are currently being trained. So we have to get our workforce for the future ready. I think we also need to look at our workforce now, because it's scary if you're a clinician and people are walking into your clinic waving their phone saying, I'm using this, what do you do? That's scary. So the workforce has to change, and if we don't, and by change I don't mean that they need to change, I think we need to help them move forward. And the reason that's important is because every day 5 million people download a health app. And so more people are using these technologies and more people are turning up with these technologies. So workforce has to be really considered. And the second thing, which we've not touched on, we've talked about reimbursement. We have to be transparent about how do we reimburse the supplier. We have got a window of opportunity before those technology suppliers leave this country and move into easier to access markets. And what they take with them is the opportunity for innovation to be used by us and our patients and the benefits that they can make, but they will also take jobs with them. And that's our future economy as well.
Henrietta?
You stole workforce from me.
Ah, sorry.
But I'm still going to talk about workforce anyway. So I think for me, listen, I've always sat on these stages and people have asked the question, how is the NHS going to compete with industry? No, there isn't any competition there. And this week I heard something that made me so happy, that somebody's done a survey of young people and NHS actually comes second to another employer, which I won't name, in industry that young people look to work in. So that, I think, gives us a good starting point. Once we've done all the training and we've enthused and enticed people into it, we need to get our house in order, because we are getting people trained and enthusiastic, innovative, and all of that. But we do not create the conditions for them to thrive, because, listen, you've been paid to be a clinician. What are you doing thinking? What are you doing transforming? And these people leave. So it's not so much about getting people trained, doing all of that. It's about the conditions they're coming in and how we hold on to them and make them continue and help them to continue thriving and innovating and challenging us to do the different things.
Clive.
I'm not going to sugarcoat it. We need to stop killing patients. And, you know, when I joined the National Patient Safety Agency 20 years ago, the NHS was killing 11,000 people a year. It's still killing 11,000 people a year, which I guess is an improvement because population's gone up. But that's 11,000 too many. And the National Patient Safety Strategy has a huge ambition of trying to reduce that by 1,000 over 5 years. That's rubbish. That's not enough. We have an opportunity now with the sorts of tools that we have, the machine learning and the AI-assisted tools. We collect so much data, we know so much about our solutions, we know so much about the care processes in hospital. The opportunity is there to learn why we're killing the patients and how to stop doing it. We need to have a better learning loop in healthcare, because without that, unless we take some time to focus on learning why this is happening, in 20 years' time, I could be on this stage and we'd still be killing 11,000 patients a year.
Well, that's probably the first time I've been on a panel where stop killing patients has been the final thing that we've closed, but a really important reminder of why we're here in healthcare, one of the things we need to do. Well, you've been an amazing panel. Tremaine, Liz, Henrietta, Clive, thank you for joining me and thank you for your thoughts. To the close of HETT North. Thank you for joining us today and staying throughout the day. Been a great set of delegates and participants, and we've had some amazing exhibitors, speakers, and of course a big thanks to everyone that has organised HETT North, participated in it, and joined in on the discussion both online and here. So thank you all, safe journey home, and see you at the next event.